Well, we classify melanomas a number of ways, and one way is simply on the sort of description of what the melanoma looks like. And there traditionally have been four basic types of melanoma that we describe. And the prognosis around them can vary a little bit, but they're well described clinical pictures that often give us an idea what this melanoma is going to do. It's not the most important ones, but certainly traditionally these are the features that we've looked at. The most common type of melanoma is the so-called superficial spreading melanoma. So these tends to be melanomas that grow horizontally or spread laterally. They can be large or small in size, and these are by far the most common that we would see. Then there's the nodular melanoma, and it really looks like a black bubble bursting from the skin, and it tends to grow up and down. And they're relatively uncommon, but they tend to grow quite fast. Then there's the acral lentiginous melanoma, and these are the melanomas that occur on the palms of the hands and the soles of the feet. These are relatively uncommon, but they also have some unique behavior associated with them. These are also the melanomas that we tend to see in people with dark skin. And also they tend to develop in people who have moles or nevi on their palms and feet. So we often tell people if you do have a pre-existing mole in your palms or your feet, you should have it removed, because that could be a precursor to this acral lentiginous type. And the final is lentigo maligna melanoma, and this is typically in older skin, people who've had chronic sun exposure, and tends to also spread laterally. It looks like an age spot that's gone bad, and these can actually become very, very extensive on the skin. They don't tend to spread, but they spread to other organs, but they do tend to spread to the surrounding skin. And this is something that we more commonly see in the elderly Caucasian patients in sites of chronic sun exposure. So these are the four types of melanoma that we've kind of traditionally looked at, and we kind of have buckets that we can kind of anticipate potentially what the melanoma may do if it left untreated, or even with treatment, what the risk is of having recurrence. Now I'm going to come back to that because we're rethinking totally how we're classifying melanomas, because what we had a pretty good idea of before in terms of prognosis really has been changing. Now, as I mentioned to you, majority of people who get melanoma survive it and live long, healthy lives. However, the ones who don't survive it, and those are the ones that come to see me as a medical oncologist, are ones who have either recurrence of the melanoma in where it started, or it spreads to other organs of the body. And that's what kills people with melanoma, is its ability to go to the brain or the liver or the lungs or the bones, and that's a problem. And so for all the people who have a diagnosis of melanoma, 80% of them have localized disease, for which the prognosis is very good. Only 12% have regional disease, and by regional disease I mean it's in the site of the skin, but it also is it has spread to one of the regional locations, and that's usually a regional lymph node. So regional disease is relatively uncommon, where they present with a lesion on their hand, and then they also have some lymph nodes under the arm that has drained the primary site and has metastatic melanoma within it. It's very uncommon to present with advanced melanoma. That means it's already spread far and near. That's relatively uncommon. In fact, we do see patients who present with widespread metastatic disease, and we don't even know where it started. We look at the skin, we can't see anything in the skin, or we look in the eyes, and we can't see anything in the eyes, and they're so-called unknown primaries. And it's interesting that sometimes the primary lesion involutes, and we think that's probably related to the body's own immunosurveillance, and has gotten rid of the primary melanoma, but the secondaries are still present and cause problems. So this is the same wheel, but these are the ones who end up with metastatic disease and are the ones who are likely going to die from their disease. So the localized ones, about a third of them develop metastatic disease. So majority of the patients do okay, but a third of the ones with localized disease develop metastatic disease. About half of the ones with regional disease develop metastatic disease, and of course those who have metastatic disease off the top have it. So it's the ones who, the percentage that is in red, those are the ones who are most likely to die from melanoma. And those are the ones that, as a medical oncologist, I really worry about and I treat. Okay, so this just, again, kind of tells that in a different way, but basically this is the 5-year survival. We measure outcome in melanoma by how many people are, the percentage of patients who are alive at 5 and 10 and 15 years. So in 5 years, those 99% of patients with localized disease are fine. The regional disease, I said half of them relapse, so at 5 years only 64% are still around. And then only 15% of those who have metastatic or distant disease are alive at 5 years with current treatments. So that's why the treatment of metastatic melanoma is particularly important issue, because these are the patients who actually die from the disease. This curve shows the proportion are alive after so many months. And you can see at 12 months, not 5 years, at 12 months, this cohort of patients, only about 25% are alive at 12 months, and usually around 10 to 15% are alive at 2 years. So this has been the traditional survival of patients who have metastatic disease, and that tells you how bad this disease can be. And so if someone has metastatic disease, they come to me. I'm the medical oncologist, so I'm the medicine man. So what medicine can I give them? Because medical treatment goes all through you. So if you have cancer all through you, then it makes sense that you'd want drugs that go all through you and treat the disease wherever. Surgery is great if it's just localized to one spot that the surgeon can remove. Radiation can be useful, again, if it's localized to one area. But when it goes all through the body, you call the medicine man, and that's me. And so that's why I tend to see the patients with the more advanced disease to try it. And it's been very frustrating. Well, I've been in the melanoma game for 20 years, and it's been really hard because we see many young people with their whole lives ahead of them develop this horrible disease, and most of them are dead within 18 months, despite what we've been trying.